Hi everyone, welcome back to Next Level Ophthalmology. Today we will be dealing with endophthalmitis, panophthalmitis and uveal manifestations in HIV. So what is endophthalmitis? It is a type of panophthalmitis. In the sense all the inner coats of the eyeball are inflamed, but this is due to infection. In the sense there is purulent inflammation of the inner coats of the eyeball resulting in the presence of exudates within the vitreous. Okay, so what are the causes? The most important and most common cause is exogenous endophthalmitis. So whenever someone says endophthalmitis, we always assume it is exogenous unless until we specify. So it is the most common, and trauma and intraocular surgery are the most common causes of endophthalmitis. So cataract, as it is the most common type of intraocular surgery performed, that is the most common cause of exogenous endophthalmitis. However, it can occur following any type of intraocular surgery. Endogenous endophthalmitis is less common, contributing to around 5 to 10% of endophthalmitis, and the infection spreads from another site within the body through a hematogenous route. Local endophthalmitis is even more rare. It is due to inflammation or spread of infections from surrounding structures. So, coming to the organisms, infective endophthalmitis is usually caused by bacteria and sometimes fungi. Sterile endophthalmitis, also known as, there are many causes of sterile endophthalmitis. There are no organisms as such, but the clinical picture is like endophthalmitis. So, this is usually seen as TAS, that is toxic anterior chamber syndrome, when pure copper foreign body which incites severe allergic reaction and tumor necrosis. So, what are the clinical features of endophthalmitis? There is pain and loss of vision following a certain trauma or a cataract surgery or any intraocular procedure. On examination, lid edema is a very important sign of endophthalmitis. Usually, endophthalmitis can occur within days of surgery. If the organism is very virulent, we will see endophthalmitis within 1 day. The cornea is usually hazy. There is severe anterior chamber reaction with a hypopyon. The edges of the wound may be swollen and gaping. There is a yellow reflex in the pupil, and there is exudation in the vitreous. Okay. B scan confirms the diagnosis, shows multiple moderately echogenic opacities within the vitreous. So this is a lot of exudation in the vitreous. So the most important thing is to prevent endophthalmitis. There is installation of povidone iodine prior to the surgery. So before you start, we instill povidone iodine within the conjunctival sac. Aseptic precautions have to be taken, sterile precautions. The instruments have to be autoclaved, having a clean OT. Tetanus toxoid injection is indicated in cases of injury. In cases of penetrating trauma, if there's a foreign body, that has to be promptly removed. Repair of an open wound within 6 hours of the injury is quintessential. Then prophylactic intravitreal antibiotics in case there is an intraocular foreign body can be done. So what is the treatment once there is infection and endophthalmitis is established? Intravitreal antibiotics and vitrectomy. According to the endophthalmitis vitrectomy study, which of the following is true? So this was a landmark trial that happened somewhere in early 2000, which included 400 odd patients with post-operative endophthalmitis. So there were a few results we'll discuss in the coming slide. Vitrectomy is indicated in all cases of post-operative endophthalmitis. No, they had clear-cut guidelines as to who will benefit from vitrectomy and who will not. Pain was the most common symptom. Yes, pain, lid edema, and diminution of vision were the common ones, and pain was the most common among them. If the visual acuity is perception of light or better, vitrectomy is preferred. No, vitrectomy was preferred when the visual acuity was less than perception of light. Visual acuity depends on the use of intravenous antibiotics. No, intravenous antibiotics have a minimal role in vitrectomy treatment. So, what did this study infer? They uh, planned the treatment based on the visual acuity. So, visual acuity, if it's better, Then hand movements, then we opt for vitreous tap or culture and intravitreal antibiotics. If it is worse than that, then early vitrectomy followed by intravitreal injection of antibiotics. So, which of the following is false about use of antibiotics in postoperative endophthalmitis? Ceftazidime is the most frequently used antibiotic for gram-negative. This is true. Vancomycin is the most frequently used antibiotic for gram-positive cover. This is also true. Intravenous antibiotics have high ocular penetration and this are mandated in endophthalmitis. This is false because intravenous antibiotics do not reach the particular concentration within the vitreous. They might be of supportive value. The concentration should not exceed the specified amounts as it can cause macular toxicity. This is also true. So the right answer here is C. So let us know what are the intravitreal injections that we can give in endophthalmitis. Intravitreal injection, usually broad spectrum antibiotics are given in the pars plana region, and the usually preferred ones are vancomycin 0.1 mg in 0.1 ml and ceftazidime is 2.25 mg in 0.1 ml. So these are the two most common antibiotics that are used. Vancomycin is used for gram positive and ceftazidime is used for gram negative. So in cases there are resistance, you can use amikacin as well. So to add to the antibiotic load, we can use subconjunctival injections as an adjunct. Again, you give vanco and ceftazidime or cefuroxime. Topical antibiotics and we can fortify them and give it as drops to the patient along with steroids and atropine is given to aid in healing. So intravenous antibiotics have a limited role but still we give them uh, so commonly used are cefotaxime, vancomycin, ciprofloxacin and ceftazidime. Oral steroids are given once the antibiotics have been started to decrease the inflammation. A 3-year-old child presented with a penetrating eye injury to the left eye 2 days back and was brought with severe redness in the eye. On examination, the following image is seen. What is the most probable diagnosis? So, if you examine the image, there is severe congestion. There is a yellow reflex in the pupillary area which is striking. There is an iris prolapse through a wound here and there is a hypopyon. So, all these are the features that indicate exogenous endophthalmitis. So the right answer here is endophthalmitis. In iridocyclitis, you do not get a yellow reflex in the pupil. Panophthalmitis, the cornea will not be so clear. The cornea will be very hazy and sloughed. Conjunctivitis will not have a hypopyon. So what is panophthalmitis? So it is a higher grade of inflammation from endophthalmitis. So there is inflammation of all the three coats of the eyeball and is characterized by complete loss of vision. There is no perception of light. There's chemosis, there's congestion of conjunctiva, there's proptosis and restricted ocular motility due to orbital edema. The anterior chamber is full of exudation and the cornea is flat. So usually the causes are similar to endophthalmitis. Endogenous infection can be seen in severely immunocompromised states like diabetes, post-transplant, immunosuppression, and malignancies. So complications include orbital abscess formation, cavernous sinus thrombosis, and meningitis and encephalitis. So treatment here is destructive procedures, that is evisceration, is recommended in panophthalmitis. So what are the subtle differences between endophthalmitis and panophthalmitis? Perception of light is usually present in endophthalmitis. Chemosis, proptosis, and restricted ocular motility is absent in endophthalmitis, whereas it is present in panophthalmitis. Treatment is you want to save the eye in endophthalmitis, you give intravitreal antibiotics with vitrectomy. In panophthalmitis, evisceration is the treatment. So let's move on to HIV and uveitis. Ocular manifestations in HIV can be due to the infection of HIV per se, or and can be due to opportunistic infections, or because of the drugs that are used for HIV and AIDS. So, the type of opportunistic infection depends on the CD4 count. So, based on this, we have a table here which say that from 0 to 199, the CD4 count that is very low. They are prone for developing ocular surface squamous neoplasias. Posterior segment most commonly CME retinitis, progressive outer retinal necrosis, candidal endophthalmitis. Okay. So when the counts are a little better, 200 to 500, you get severe blepharitis, dry eye, Kaposi sarcoma, molluscum contagiosum, and zoster ophthalmicus. In the posterior segment, you can expect toxoplasmosis. Usually, toxoplasmosis in HIV/AIDS tends to be widely spread and diffuse compared to that in immunocompetent, and there is minimal amount of vitritis. You can have intermediate uveitis, retinal vasculitis, and tuberculous uveitis. So when the count is a little more than 500, HIV retinopathy is the most common manifestation. What is HIV retinopathy? There is presence of cotton wool spots like lesions in the posterior bone, might be associated with microaneurysms and hemorrhages. Immune recovery uveitis. It is defined as a loss of vision by at least two Snellen's charts in the absence of CME retinitis with 2 points. So immune recovery uveitis happens when you have initiated HART, and especially if the patient has had CME retinitis. When there is healing due to an immune recovery, you get severe recalcitrant uveitis. So it usually tends to be pan uveitis, and it's very difficult to treat, and you need aggressive steroids. So here you will have vitritis, cystoid macular edema, and epiretinal membrane formation. And the severity of immune recovery uveitis depends on the area of CME retinitis. So the points here are decrease in two Snellen lines with at least two of these 4 points. So there has to be iris elsewhere in the body, in the sense immune reconstitution syndrome elsewhere in the body on a patient with on heart. So these are the diagnostic criteria for immune recovery uveitis. The treatment is aggressive use of steroids in all particular ways possible. Systemic steroids, periocular steroids, and topical steroids. You can even use a intravitreal steroid implants. So this is about today's class. We will meet at the next class with the last session on Uvea. Thank you.